bad leak rate. So most patients with rectal cancer surgery do not need temporary ileostomies when they have surgery. Talk a little bit about radiation. There's only been one NIH consensus panel on radiation, and they concluded that, as you can see here, that postoperative chemo and radiation therapy is indicated in patients with T3 tumors or node-positive patients. This is as a result of the GI tumor study group in the 70s and 80s, which showed that post-op radiation helps. Well, as you know, almost all radiation now is administered preoperatively, and the reasons are listed on this slide. One, is tolerated much better. If you have somebody walk off the street with rectal cancer, they will tolerate neoadjuvant chemoradiotherapy very well. If you take out their rectum, they don't feel so good when you start radiation, and they just don't tolerate it as well. In theory, there's a better biologic effect. Oxygen helps radiation kill tumors, and a well-oxygenated rectum probably has a better cancer response to radiation than one that's ischemic after surgery. The most important from a surgical standpoint, in my opinion, a functional standpoint, is the third bullet there, and that if you do preoperative radiotherapy, you radiate the rectum, you take it out, you throw it away, and you replace it with new tissue, which is non-radiated. The function is better. If you do a colon cancer, rectal cancer operation, and then radiate them post-op, the patients do crummy. They get radiation fibrosis in their neorectum and have terrible bowel function. Downsizing is frequently another reason to get radiation ahead of time. The Germans took on the task of trying to prove that preoperative radiation is better than post-operative radiotherapy. They did a huge randomized trial, and you'll notice a trend here that all the good randomized trials in surgical issues are not done in the United States anymore. They're done in the Netherlands, Germany, and the UK.